Welcome everybody to ICON 2022. This is the sixth biennial um, conference of Indus Hospital. And this year the topic is Beyond the Call of Duty. And you are in the vascular session of the ICON 22, which will start just in few minutes. The vascular session is divided. My name is Dr. Khalid, and I'm a vascular surgeon in Abu Dhabi. And for those who don't know me, this vascular session is divided into three parts. The first part will be type B aortic dissection, and we have four presenters. The second part will be hot topics that will be chaired by Dr. Ilyas Sadiq. But the co-chair Farhad Barlas couldn't join us today because he had some commitments. So I will help Dr. Ilyas in this session. The last and the most interesting session, which I think for all the trainees in Pakistan, is the educational symposium, which will be chaired by Professor Muhammad Iqbal and co-chaired by Dr. Ziyad Sufi. I just received a call from Dr. Ziyad Sufi that he is involved with a complicated transplant at the moment. So he may or may not be able to join, but he sent his apologies. So that will be, this will be the whole session, a 2-hour session, and we'll start with our first presentation. And our first present, and I welcome my co-chairman, Dr. Professor Ahsan Bhatti, who is a consultant vascular and endovascular surgeon at Combined Military Hospital in Lahore. So with this, we will start our session, and the first speaker is Dr. Maaz Syed. Maaz is a senior vascular trainee in the UK and a PhD candidate at the University of Edinburgh. He worked on novel imaging and circulating biomarker in patients with acute aortic dissection and acute aortic syndromes. Maaz won a few prizes presenting his work, and his runner-up prize was at the Society of Cardiovascular for CT conference in 2018. The second prize was European Society of Vascular Surgery in 2019, where again he was a runner-up. And then Maaz won the first prize of Scottish Sharp meeting in 2019, and he won twice the prize of Solcon Prize, which is the UK Vascular Society Solcon Prize, very prestigious prize, in 2020 and 2021. He is the first candidate since the start of the Vascular Society in the UK who has won this prize twice. So all his prizes were won for his work on the aortic dissection and acute aortic syndrome. So today he will be speaking about the acute aortic syndrome and the future directions in the field. So can we just share the slides, please? Can we please start the first presentation? This is not the first presentation. Can you bring Maaz Syed's presentation, please? Sorry, some technical glitches, but Jawil will be starting the first presentation soon. I'm sorry for all these technical issues, especially when you are not present there. But inshallah, we'll just get on with the first one.
May I ask you something, Khalid bhai? How many people are participating live in the conference? Because obviously I'm not there, and I'm not sure what is the situation or the policies are keeping in view the current COVID wave. Do you have any idea?
I'm not sure. I'll just check with them. I think there is some issue with the.
Now, these are rare conditions, and they pose challenges in diagnosis. We must put ourselves into the shoes of the emergency physician tasked with diagnosing this condition to understand the scale of the morbidity. Here's our patient with chest pain, and their symptoms could be coming from a multitude of etiologies. Let's assume that they've got aortic pathology. Well, our emergency physician would have to see 99 patients with acute myocardial ischemia before they find their first patient with acute aortic syndrome. And if we looked at all patients presenting to the emergency department with chest pain, it's actually much more difficult. The emergency physician sees 300 patients with other causes of chest pain before they identify our one patient with acute aortic syndrome. What we're asking is a non-specialist.
Guys, some technical issues. I was just told that the reason why we cannot see it properly is we are in the backstage, and she sent us a link for viewing this the presentation. Only the person जो कि present करेगा will be on the backstage. So let's log in to the different link. So just please just bear with me. Let me check which link is this.
They suspect it and diagnose it. The specifics clinically rely initially on resuscitation. Your patient is often critically unwell, and early anticipation of the critical care team is necessary, ensuring that patients have a safe airway, that their breathing is secured, and their hemodynamic state is stabilized is the initial resuscitation of all patients in whom a diagnosis is still to be made. Diagnosis of acute aortic syndrome requires a trifecta of tools coming together. The clinical state, patients will often present with back or chest pain. This can be tearing in nature, but of course, patients can present or describe their pain in a variety of terms. Patients are often hypertensive when they present, and they may have atypical presentations of visceral limb ischemia that don't all entirely add up. Patients often require blood tests and will get a routine set of blood tests. But things like a lactate can help you determine end organ ischemia. We're particularly interested in D-dimer and troponin. We'll speak a little bit more about D-dimer, but focusing on troponin, this is really a marker of myocardial damage. This could be happening because of primary coronary disease, but it could also be part of the acute aortic syndrome. The diagnosis really hinges on imaging. Now, chest X-ray is often performed as a first radiographic investigation, and it is useful to exclude something like a pneumonia, but it's notoriously unreliable for excluding aortic pathology, and it should never be used for that basis. The diagnosis hinges on CT scans of the aorta. This should include the entire aorta from the thorax to abdomen, I would argue down to the femoral vessels and beyond, because if patients that are unwell, you do need to know what your endovascular access looks like at this stage, should this be required. A special mention of hypotension. We said that most of our patients are hypertensive. Well, if your patient is hypotensive, one of two things has happened. The heart has become compromised, or the aorta has experienced a herald bleed and the patient suffered acute intravascular loss. The heart can be involved in a number of ways. Either the coronaries have been involved within the acute aortic syndrome process and patients are experiencing myocardial ischemia. A bleed around the heart is manifesting as a tamponade, or the aortic root has become acutely dilated and patients have severe aortic regurgitation and incompetence, and they're now unable to mount a blood pressure. And these are rather pressing states and they warrant urgent investigations. Of course, once the diagnosis of acute aortic syndrome is made, then you need to initiate some systemic monitoring. There's three things that we need to do. The insertion of a urinary catheter helps determine hypovolemic state, but it also acts as a proxy of end organ ischemia by measuring renal perfusion. Invasive blood pressure is required, usually in the radial artery, because you're about to deliver these patients with intense blood pressure lowering medication. And finally, telemetry, ECG telemetry is necessary because if myocardial ischemia does occur, you need to know about this early. Your patients are going to need to go somewhere where you can offer them monitoring, and so it's important to get in touch with critical care at this stage to offer a level 2 bed so you can keep a close eye on these patients. Now, D-dimer is a degradation product of fibrin, and it's elevated in hemodynamic states with thrombus is formed and broken down. And that's something that happens in acute aortic syndrome. A large meta-analysis of 22 studies and 5,000 subjects from not too long ago found that a D-dimer cutoff of 500 nanograms per mil actually is remarkably sensitive at finding acute aortic syndrome. However, it's not very good at excluding other causes of acute aortic syndrome. The specificity was only 0.6. What this means that if there is aortic disease, then D-dimer will be raised. However, it's not very good at differentiating acute aortic syndrome from things like a pulmonary embolus or acute myocardial infarct. Thus, D-dimer is useful as a rule-out test. If your D-dimer is negative, it's unlikely you're having acute aortic syndrome, and that's where its utility lies. We said that the diagnosis really hinges on a CT angiography. Now, there's a few parameters to mention about CT angiography. It's remarkably sensitive and specific. It'll find 99 out of 100 acute aortic syndromes if this is the case. But the CT scan must be ECG gated. What I mean by that is the image is acquired at exactly the same point in the cardiac cycle, and that reduces blurring artifact around the heart and ascending aorta. Here's a patient who's gone for a non-ECG gated CT, and it looks like they've got a dissection flap. On the other side of the aorta, there's a blurry artifact. The same patient has an ECG gated CT and the aorta looks normal. So it's very important that the ECG is gated, and I would put aside concerns related to increased radiation exposure with this imaging modality, because the risk of missing an acute aortic syndrome in young patients poses a much greater degree of harm than the marginal increase in radiation they would be exposed to with ECG gating. These are the two main tests we're interested in acute aortic syndrome. D-dimer, which is more useful as a rule-out test to exclude acute aortic syndrome if the value is below 500, and CT angiography, which really is essential to confirm the diagnosis. Now, acute aortic syndrome, this saga is often unfolding in a time-poor setting, and it requires a coordinated effort. And I'd like to speak a little bit about what the role of the vascular surgeon is. And this is how I approach this. It's a hierarchical fashion of organizing our teams and logistics to deliver care. We need to get in touch with our immediate healthcare team, and that's people within the vascular surgery team. And this depends very much on your local structure. But the vascular surgeon must also communicate with a wider healthcare team. And of course, there's a final halo of individuals to discuss, and that's people outside of the healthcare team. This is what it looks like. The vascular surgeon in the center coordinating care must interface with members of the emergency department, specialists in critical care. If the patient is going to require surgical intervention, then anesthetics and the theatre department must be informed promptly. We've already discussed how important it is to get prompt imaging, so your radiologist needs to be on board. Of course, they might also be involved from an interventional point of view. And finally, involvement of the aortic root at a type A morphology necessitates the involvement of cardiac surgery. And a vascular surgeon must be able to communicate and interface with all of these specialists to deliver care. Outside of the healthcare team, yes, we get carried away with delivering care, but we must remember it comes back to the patient. We must inform our patients of what's going on with them, and if they wish, their families. They must understand that we're going to do whatever we can to improve their care, but there is a real risk to life in this condition. And that's what leads me to an aortic dissection pathway. We've said that there's a large degree of uncertainty in a dynamic situation. And so to deliver and streamline care, what you need is a structured, premeditated plan on managing these patients. This is the pathway that we've developed in Edinburgh. It's called the Think Dissection Pathway, and it lays out very specific objectives and very specific endpoints if you suspect somebody has an acute aortic syndrome. There's a lot of information here, which I won't go into all of it, but if you're interested in downloading this, please take a screenshot or a photo of this QR code where you can access it, and I will also present this information to you later on in the talk, so you have time to prepare your equipment. I'd like to speak briefly about future directions because there is hope. In Edinburgh, we've been working on a molecule called plasmodesmosine. Now, here's histological staining of elastin in somebody who's had an acute aortic syndrome, and you can notice a band of reduced elastin in these patients. Elastin is held together by a molecule called desmosine, and when elastin breaks, as is occurring here, desmosine is released into the bloodstream, and you can measure it as a circulating biomarker. We suspected this would be the case in patients with acute aortic syndrome, and indeed that's what we found. Compared to healthy controls who had relatively low desmosine, patients with acute aortic syndrome had a significant rise in plasma desmosine when they presented at the red line, and this desmosine remained elevated for many years after the event, suggesting ongoing chronic degeneration of the aorta. In a regression model, we found that patients presenting to the emergency department had a threefold increase in plasma desmosine compared to healthy controls. And this is incredibly promising because plasma desmosine in combination with something like D-dimer may offer a blood test which is both sensitive and specific to diagnose acute aortic syndrome and better identify patients that need to go for a CT scan. We've covered a lot of information in this talk. Here's a summary. Acute aortic syndrome is a rare condition, and to diagnose it, we must have a program of education and feedback for our clinicians in the emergency department. The clinical presentation is vague and their symptoms are unreliable. A D-dimer may help exclude acute aortic syndrome, but there's a race to an ECG-gated CT angiography to clinch the diagnosis. The initial management necessitates a coordinated multidisciplinary effort, the center of which is the vascular specialist. And the best way to improve care for this vulnerable patient group is to develop a dedicated treatment pathway, which is tailored to your specific institution. Finally, the future is bright, and there is work being performed to improve the diagnosis of this condition. I did promise I would give you a link to our pathway, and here it is. Please do get in touch with me if you find this pathway useful, if you have any feedback, and importantly, if you want to develop a similar pathway for your own unit, I'd be very keen to hear your experiences and offer advice and get involved. Thank you very much.
Thank you very much, Maaz. Sorry for this technical hitches. I think we'll be okay from now onward. I will ask my co-chair to introduce our next speaker. Ahsan, can you introduce the next speaker, please?
Khalid bhai, can you hear me?
Yes, I can hear you.
Right. So our next speaker is Dr. Omar Ahsan, who will be talking about conservative management of type B aortic dissection. Dr. Omar Ahsan is a consultant vascular and endovascular surgeon at Shifa International Hospital, Islamabad. He did general surgery training from Mayo Hospital, Lahore, and cleared his FCPS general surgery in 2002. He did his general and vascular surgery training at the Wales Deanery in the UK and cleared his FRCS in 2009 and went on to do an endovascular fellowship from Manchester in 2010. And then he was appointed as consultant vascular surgeon at the University Hospital North Midlands from 2011 to 2015. And currently he's working at Shifa International Hospital. So can we please have the presentation of Dr. Omar Ahsan, please?
Assalamu alaikum. My name is Dr. Omar Ahsan. I'm a consultant vascular and endovascular surgeon at Shifa International Hospital in Islamabad. And the topic I'm going to discuss today is type B aortic dissection, medical management of this condition. So we've already gone through some presentations, and there might be a little bit of repetition of what I'm going to be saying here. But I'll focus mainly on medical management. Aortic dissection is defined by separation of layers of aortic wall by an inciting intimal injury. As a result, blood starts flowing through the different layers of the aortic wall, therefore creating two lumens. Different variants of classically described aortic dissection include intimal tear without hematoma, penetrating aortic ulcer, aortic intramural hematoma, or peri-aortic hematoma. The incidence is estimated to be about 5 to 30 cases per million per year. The more common in males, about 2 to 3 ratio 1 is the male-female ratio. Approximately 75% of dissections occur in those aged 40 to 70 years, and the peak is around 50 to 65 years. Hospital-based mortality is approximately 30%. Acute aortic dissection is associated with high mortality and morbidity, which is the highest in the first 24 to 48 hours. Patients with chronic aortic dissection have a better prognosis. The classification for aortic dissection can be temporal or anatomical. Temporal classification is based on the time. It can be hyperacute, acute, subacute, or chronic. Whereas the anatomic classification are the two widely known classifications of DeBakey or Stanford, depending on the entry point or the intimal tear and the involvement of the segment of aorta. Type B aortic dissection can present in different ways, but the most important thing that we look at is whether it's complicated or uncomplicated. Complicated is an aortic dissection in which there is evidence of malperfusion. There is rapid expansion or of impending or frank rupture, uncontrolled pain, or refractory hypertension. Other than these, all the other aortic dissections are considered to be uncomplicated. Approximately 25% of the patients can present with type B aortic dissection, which are acutely complicated. Clinical presentation, usually it starts with pain, acute onset, severe chest or back pain. Other symptoms or signs can be related to the progression of dissection or to end organ malperfusion, like shock, syncope, heart failure, myocardial ischemia, stroke, paraplegia, or ischemia involving the mesentery or extremity. Investigations electrocardiogram should be obtained in all patients. In low-risk patients, a chest X-ray may be a good enough investigation to demonstrate any aortic pathology or establish any alternative diagnosis. However, patients who are at high risk clinically of having an aortic dissection, and definitive investigations like a transesophageal echocardiogram, computed tomography, or magnetic resonance imaging should be performed to establish the diagnosis as soon as possible. Moving on to the medical management. The priorities in acute management include resuscitation for hypertensive patients, initiation of anti-impulse therapy, pain control, and identification of malperfusion syndromes or other complications that indicate the need for repair. Subsequent management it consists of ongoing pain control, titration of medication to maintain heart rate and blood pressure at desired targets, transition from intravenous to oral medication, counseling of patient and family, and most importantly, lifelong imaging surveillance to keep an eye on the type B dissection. So in acute period, the management should be in an intensive care unit, depending on the hospital. It can be in a surgical intensive care unit or in coronary care unit. The most important thing that we are looking at is continuous blood pressure monitoring via an intraarterial catheter, cardiac recording of and monitoring of cardiac rhythms, hemodynamic surveillance, keeping the patient pain-free by regular analgesia, and monitoring the urine output, that is keeping an eye on the kidney function. The laboratory tests that are done routinely, like complete blood count, electrolytes, coagulation parameters, and D-dimers, but also keep in mind the malperfusion signs, and therefore keeping an eye on the liver function test, renal function, and lactate is also important. So what is anti-impulse therapy? Anti-impulse therapy is to achieve targets of systolic blood pressure of 100 to 120 millimeters mercury. That is keeping a mean of between 60 to 70 millimeters mercury. Heart rate also needs to be reduced to around 60 beats per minute. So the anti-impulse therapy consists of controlling heart rate and blood pressure, and the idea is to decrease aortic wall shear stress, to minimize the tendency for dissection to propagate, and to minimize the development of complications. Combined antihypertensive drug therapy is usually required. Different pharmacological agents are used for this. Initial therapy is usually started with the beta blockers like labetalol, propranolol, or esmolol. And then systemic arterial pressure and shear stress both need to be controlled, and therefore IV nitroprusside, IV labetalol, or calcium channel blockers can be added. Labetalol especially mentioned in both the areas because it has dual effect of decreasing blood pressure and cardiac contractility. So what we are trying to achieve is a decreased force of myocardial contraction, which slows down aortic expansion and possible rupture. Patients with optimal heart rate and systolic blood pressure control have better outcomes with a reduced rate of aortic expansion and rupture. In addition to beta blocker, aortic expansion and survival are improved for patients who receive calcium channel blockers for maintenance therapy. And once the heart rate has been achieved and patient is tolerating an oral diet, intravenous drugs can be changed to oral route. So the different drugs, as I've mentioned, beta blockers, esmolol, labetalol, verapamil, diltiazem, nitroprusside, or nicardipine are used, and the doses can be seen here. The most important thing is the vasodilator therapy should only be started once the heart rate has been controlled with beta blockade. Other than this, there also have been suggestions of supportive care like exercise limitation, which is unclear but recommended to minimize aortic shear stress. Looking for associated genetic conditions, which can be syndromic or non-syndromic, that's also been proposed. And even screening first-degree relatives should also be considered at an appropriate time. So patients who have been managed medically, the surveillance for these patients is extremely important. The surveillance can be done with any preferred modality of investigation that is available. But what has been recommended is to perform a baseline thoracic magnetic resonance imaging or computed tomographic angiography prior to discharge. In our hospital, we keep an eye on these patients with regular CT scans, and the follow-up examinations at 3, 6, and 12 months are recommended, and then annually, even if the patient remains asymptomatic. Why are we doing the surveillance imaging? It is basically to keep an eye on the type B dissection. Its extension or recurrence of dissection can be picked up at an earlier stage if the patient is in the surveillance program. Aneurysmal degeneration can be kept an eye on to offer management at an appropriate size, and malperfusion can also be detected early. INSTEAD trial was carried out a few years ago, and it basically had 140 patients. 72 of these patients had an additional endovascular treatment besides the medical management. And the primary endpoint was all-cause death at 2 years, where secondary endpoints were aortic-related death, aortic remodeling, and disease progression. The important thing here is that the INSTEAD trial did not show any significant advantage of endovascular treatment in comparison with optimal medical therapy at 2-year follow-up. No difference was found between two groups for aortic-related death and disease progression. However, it did show the effectiveness of endovascular therapy for false lumen thrombosis, which was achieved in 90% of cases. And therefore, from a medical management point of view, the importance of tight blood pressure control and close surveillance was also found to be important. Together with the non-significant procedure-related complications highlighted, these results support a complication-specific approach instead of endovascular therapy for all stable type B dissection. I'll show you a couple of cases. Thank you.
Thank you very much, Dr. Omar, for a very nice presentation. The next speaker is Dr. Zahid Raza, who will be talking about open repair for type B aortic dissection. Dr. Zahid qualified
from... Thank you for asking me to...
Right. Dr. Zahid qualified from the University of Dundee and then took up a higher surgical training in Edinburgh. He was appointed as consultant at the Royal Infirmary of Edinburgh in 2002. His main interests include vascular access, carotid surgery under local anesthesia, and open aortic surgery. He is on the Council for Royal College of Surgeons of Edinburgh and is the current exam convener for the Royal College of Surgeons of Edinburgh. He has just taken a post as a vascular surgeon in Abu Dhabi. So I welcome Dr. Zahid for his presentation.
Thank you for asking me to give a talk on open repair of type B aortic dissection at ICON 2022. These are my disclosures, and essentially type B dissection, there's an entry tear and often a re-entry tear, but if there isn't, then usually the false channel becomes thrombosed. The type B dissection is relatively common, but it varies in different countries. So the incidence will vary between 5 to 15 per 100,000 population. Now, the vast majority of these patients can be treated conservatively, especially during the acute phase. But it's important to keep these patients under review because in the acute phase, certainly rapid expansion, organ malperfusion is an indication for any active intervention. It's usually in the first 2 years of follow-up that there is a problem with the conservative group of patients. So it's ideally 6-monthly serial CT scans are required. And if the thoracic diameter of the aneurysm has increased to around 5.5 to 6 centimeters, that's our threshold for intervention. And if there is no screening or subsequent follow-up of these patients, around a quarter of these patients will die at 3 years. So what are the indications for surgery? Well, we all know that TVAR has taken over the majority of patients who require intervention, but open surgery is still important and is required for patients who have impending rupture or they've got unfavorable anatomy for TVARs, and if they have a chronic post-dissection aneurysm, if there is any organ malperfusion, if there is extensive atherosclerosis where sealing is not going to be guaranteed with a TVAR device, and of course, patients with connective tissue disorders. The complications of open surgery are relatively high, and you're looking at a mortality in most units between 10 to 15%. This is inpatient and 30-day hospital mortality. The stroke risk is about 5%, and I remember as a junior, cord ischemia was actually quite high, but certain preventive measures have reduced this from around 20% to 5% over the years. And about 10% of patients will have to undergo dialysis because of renal dysfunction. And surprisingly, up to a third of patients may require re-exploration, and generally the commonest cause is for bleeding. How do you avoid cord ischemia? Well, there's various strategies now that have that the surgeon and the intensivist can use. So CSF drains are fairly universal. Active cooling, especially if the patient is on heart bypass, and maintaining the left subclavian artery patency. And that's important to, in some patients, especially when you're doing a TVAR, to do carotid subclavian bypass to maintain the patency of the subclavian. And limiting spinal cord collateral steal by anastomosing the large intercostals, and of course post-operative hemodynamic monitoring, where you're aiming to have a reasonable mean arterial pressure. Let's not forget hybrid procedures, because most of the open surgery is done in combination with stenting, and this form of debranching allows a more robust proximal placement of a TVAR device. So here's a patient who has had fairly extensive debranching, and this is their brachiocephalic, and this is their debranching to the left carotid and the subclavian artery here. Subclavian origin is often plugged with an amplex, and then this means that the stent graft can actually go quite proximal, just proximal to the aortic arch, so that you get a better sealing for these patients. However, the open procedure is quite tedious. It takes anything from, you've got 5 to 16 hours. And what some units do is they'll do perfusion to the mesenteric or renal vessels selectively, or they can do the repair from the proximal part and segmental clamping, which basically means that when the patient is on left heart bypass, the vital organs are being perfused, so the ischemia time is reduced. And this is what you're hoping for, an end result where you've reimplanted the main intercostals, a coral patch for the mesenteric and renal vessels, and often a jump graft to the left renal artery. So what's the comparison between open and TVAR? Well, the initial mortality, as I mentioned, is high, but once the patient gets out of hospital, the long-term mortality is actually quite low. Whereas the initial mortality for TVAR is half that of the open repair. But remember, the long-term reintervention rate is similar to what you have for EVAR patients, i.e. about 1 in 5 will require some form of reintervention. Ideally, the younger fit patients will do well with the open repair, and the older patients with comorbidities is better suited for TVAR. And you don't really need a long-term follow-up for the open group, whereas long-term follow-up is essential in the TVAR group because of the problem with endoleaks and sac expansion. And open repair is better for connective tissue disease patients, such as the Marfan's and the Lewis-Deutz syndrome patients, whereas in connective tissue disorders with the TVAR, then remodeling doesn't occur and sac expansion rate is quite high. So in conclusion, surgery does remain the gold standard for type B dissection, in my opinion. However, if you look at the whole population, a very small proportion will actually undergo open surgery. And TVAR is useful for the uncomplicated dissection. And also, in a lot of cases, it's a bridge for secondary open surgery, when you can give surgery to patients who have had a period of stability, and then you can go for an open procedure. And of course, TVAR requires long-term follow-up to look for any problems such as malperfusion, aneurysmal enlargement, and impending rupture. Thank you very much.
Hello, everybody. My name is Yasir Sulaiman. I'm a vascular and endovascular surgeon in Abu Dhabi, and I will be speaking to you today regarding endovascular repair in type B aortic dissection. I know my colleagues have already addressed what I'm about to mention here in this slide, but I'd like to go over some basic concepts before we start dwelling into the use of TVAR in aortic dissection. So first, what is aortic dissection type B? This is a condition that occurs when a tear happens in the intima of the arterial wall, which then allows blood flow to propagate within the medial layer, creating a flap, which then divides the aortic lumen into a true lumen and a false lumen. This most commonly happens just distal to the left subclavian and is usually associated in about 90% of cases with a re-entry tear distally. And then the next definition that I'd like to go over is the basic definition of a TVAR, and this is a thoracic endovascular aneurysm repair, which is a transluminal introduction of a covered self-expanding stent into the thoracic aorta, typically through a transfemoral approach. Another basic concept that I think is worth going over before we get into the subject is when there's a dissection, there's obviously a true lumen and a false lumen. And this dissection flap, when it separates, then it becomes a source of malperfusion of side branches. And this can happen because of a static obstruction, when the dissection extends into a lumen, thus into a lumen of a side branch, thus narrowing it, and often with formation of thrombus within that side branch. So that's one mechanism. The second mechanism, which is actually the more common mechanism, is a dynamic occlusion, whereby the dissection flap protrudes and compresses the false lumen and then occludes the side branch. And then this phenomena tends to be exacerbated by a rise in blood pressure. So the higher the blood pressure, the more expansion you get in the false lumen and more compression of side branches, leading to dynamic obstruction. And also, naturally, when a dissection occurs, this weakens the aortic wall, leading to rupture of the aorta in this condition. This tends to happen more commonly when the false lumen is greater than 22 millimeters in diameter. So these are the two issues here: the weakening of the vessel wall leading to rupture, and the dissection flap leading either to a dynamic obstruction or a static obstruction, and sometimes a combination of the two. It's important also to go over the classification of aortic dissection before we go into the treatment. And there are three important ways that we classify aortic dissection. And it's important to understand all three of them because they have a direct implication of how these are treated. So the first is an anatomic classification based on the anatomic distribution of the dissection. The second is based on chronicity, that is to say, for how long has the dissection been there for, and then the presence of complications. So if we look at an anatomic classification, there are two classification systems that have been around for a long time. That's the Stanford and the DeBakey classification. I'm not going to go into them because I know they've been addressed in previous talks. But I would like to point your attention, and obviously it's very important to understand both classifications. The more applicable one is certainly the Stanford classification in clinical practice. The newer classification, which has been proposed by the Society of Vascular Surgery and the Society of Thoracic Surgeons, came out in 2020, And this is actually quite an interesting classification system because it takes into account not only where the entry point is, but also the proximal and distal extension of the dissection, which is information that is important in making decisions about treatment that has been lacking in the Stanford and the Baker classifications. So, for example, a type A dissection would have an entry point in zone 0. This classification divides the aorta into about 12 zones. And so if you have a type A, then the entry point would be in zone 0. And that is from the beginning of the ascending aorta to the innominate artery. A type B dissection is anywhere in zone 1 or more distal. And I think this will become more widely used with time because it does lend itself very well to planning of the procedures and allow us to communicate more precisely. In terms of classification for chronicity, and this is important when we decide when to treat these dissections. So it's important to know these timelines. People disagree, and it's controversial whether we should use the hyperacute window or not. But certainly we agree on the acute, subacute, and chronic types of the dissection. So an acute type B dissection is a dissection which has occurred 1 to 14 days previous. Subacute is 15 to 90 days, and chronic if it has been there for more than 90 days. And we'll talk about that later on in terms of when we treat these aneurysms, or these dissections, I should say. In terms of the clinical classification, this is based on whether these are associated with complications or not. So 2 broad categories, complicated and uncomplicated. The complicated constitute about 25% of type B dissections, and these are of 2 types, either rupture or end-organ ischemia or malperfusion. Then the uncomplicated is constitute less than about 10% of the type B dissections, if you exclude the high risk, which we will talk about in a minute. These tend to have late complications in about a quarter to half of these. They are initially stable and have low in-hospital mortality of less than 10%. They have no evidence of malperfusion, and their pain is well controlled, and blood pressure is well controlled with medications. So this is the uncomplicated, no rupture, no malperfusion, and you can control the blood pressure and the pain with medications, and they don't have any high risk elements in them. And we will talk about what are the high risk markers when it comes to a type B dissection. So this is kind of a subgroup of the uncomplicated patients. They don't have a rupture and they don't have a malperfusion, but if they have clinical and radiologic features that indicate that these patients may be bad players. And these are uncontrollable pain or hypertension, bloody pleural effusion, readmission. These are essentially the clinical high-risk features. And then there are radiologic features that we look for. And these are an aortic diameter of greater than 44 millimeters, a false lumen that's greater than 22 millimeters. And if there's radiologic evidence of malperfusion, it's not mild perfusion, but it's malperfusion. And also an entry tear that is in the lesser curvature, and also entry tears that are greater than 10 millimeters. These tend to be signs of poor prognosis in terms of aneurysmal dilatation and a need for further procedures. So 3 groups: complicated, uncomplicated, and then uncomplicated with high-risk features. Now let's talk about the role of TVAR in type B aortic dissections. So certainly TVAR has developed as a first-line treatment option for patients with complicated acute type B dissection. The aim of using a stent graft in the aorta is to obviously treat a rupture if one is there, and also treat malperfusion by covering the primary tear to reduce the flow into the false lumen. And the reduction in false lumen perfusion helps obviously reduce the extension of the dissection distally and also potentially proximally, and will also contribute to false lumen thrombosis and subsequently aortic remodeling and aortic wall stabilization, preventing expansion and rupture. And although no randomized controlled trials have demonstrated this, there's an increasing evidence that in complicated acute type B dissections, emergency and urgent interventions have beneficial impact. So yes, no randomized control studies, but definitely from the data we have from retrospective studies and observational studies, there's data that shows that TVAR use in emergency and urgent interventions in complicated acute type B dissections is beneficial. Now, if we look at some of this data, there are a number of studies out there. I've included a few here on the slide, and I'll start by a prospective multicenter European registry, which published in 2011. And this demonstrated if you use TVAR in complicated type B dissection, you have about a 8% 30-day mortality, a stroke rate of about 8%, and spinal cord ischemia of 2%. Similar data have been corroborated also by a number of meta-analyses, which show a hospital mortality of between 2.6 and 9.8, and neurologic complications of up to 3%, with very good technical success rate in these cases. Additionally, a retrospective study have looked at 71 patients and compared endovascular treatment of complicated type B dissection versus open surgery versus medical therapy, and found that there's improved survival at 1, 3, and 5 years for patients who were treated with TVAR as compared to open surgery and medical therapy. Now, if we look at the uncomplicated acute type B, the most commonly cited studies are the INSTEAD and the INSTEAD-XL. And basically, this has shown that at 2 years, there's no difference between medical therapy, open surgery, and TVAR. But if you look at 5 years, there seems to be a significant difference in terms of the amount of aortic remodeling and improved outcomes in the TVAR group. And that in this study also seems like the best benefit is reaped when the procedures are done in the 2 weeks to 3 months period. So in summary, uncomplicated patients as a whole don't seem to benefit from intervention, but if you select the high-risk group, they seem to have a benefit from TVAR. Now, if we kind of cover the management again, but I know this has been covered in previous talks about aortic dissection in an earlier session. So some of the initial management and considerations are very important to stress. Number one is that you need to differentiate early on between complicated, high risk, and uncomplicated type B dissections based on clinical and radiologic presentation. It's very important to institute blood pressure, heart rate, and pain control regimen using A-line and strict criteria for blood pressure and heart rate, keeping the blood pressure between 100 to 120 and the heart rate less than 60. Use beta blockers to start with, coupled with pain control, and then add vasodilators to a regimen. This is very important. This helps to lower the blood pressure, decompress the false lumen, and decrease the insult on the aortic wall, and reduces rupture, propagation, and malperfusion. In terms of the management for uncomplicated, obviously one would still use the medical management to control pain, blood pressure, and heart rate, and consider TVAR selectively. And we have no clear data yet to guide us in terms of treating patients who are uncomplicated without high risk, and only select patients for TVAR if they're uncomplicated, if they demonstrate high-risk features which we have already discussed previously. And I've included here also the importance of having a surveillance protocol. This is happens to be the one we use here, is initial CT angiogram on presentation at 72 hours, 3 months, 6 months times 2, and then 12 months. But there are different variants of this protocol. It's important to have one for strict follow-up, as about 25% to 50% of these patients will go on to need a procedure. In terms of complicated type B dissection, we've already discussed the blood pressure, heart rate, and pain control. This is standard for all acute type B dissections. TVAR is the preferred treatment for treatment of acute type B dissection, and occasionally one needs to do an adjunctive procedure in the form of a fenestration or stenting of a side branch. Fenestrations are helpful when when you have a pressurized false lumen that is still compromising side branches in spite of sealing the entry tear with a TVAR. So this can be found out through angiography or IVUS. So if you seal the entry point and you still have a pressurized false lumen compromising side branching, consider fenestration. Another option would be to use a dissection, which is an uncovered stent across the side branches. Side branch stenting is another adjunctive procedure that sometimes one has to use, and this is to treat a static obstruction in a side branch. So first you re-expand the true lumen and decompress the false lumen by putting the TVAR in. Then you interrogate the side branches through angiography and or IVUS, and if you have a static obstruction of a side branch, then you can stent it after completing the TVAR. Open repair is an alternative to TVAR if it's not available or if it's unsuccessful. So to summarize, what are the indications of TVAR in acute type B aortic dissection? So the indications are complicated type B dissection, that is to say, rupture with a type B dissection, or malperfusion with a type B dissection. Second is the high-risk group, and that is patients with refractory pain or hypertension in spite of adequate treatment regimen, having a bloody perfusion, a pleural perfusion, aortic diameter greater than 44 millimeters, or false lumen greater than 22 millimeters, a patent false lumen with partial thrombosis, readmission, and radiologic evidence of malperfusion, not mild perfusion, malperfusion, and an entry tear on the lesser curve, or an entry tear greater than 10 millimeters. These are the high-risk features in uncomplicated patients that allows you to, based on these criteria, to select them for TVAR. So Then in terms of timing of TVAR, in complicated, obviously it's an emergent procedure. In uncomplicated cases, the timing remains controversial. We perform them, and the general recommendation is to perform them somewhere between 2 to 4 weeks. And the reason for the controversy is that there seem to be an increased risk of the procedure when performed in the acute phase versus the subacute phase, that is to say, after the 2 weeks. Having said that, the remodeling that happens in the aorta following a TVAR seems to be more pronounced when the TVAR is done early. So these are the sources of the controversy around this point. But certainly for uncomplicated, it is recommended to wait 2 to 4 weeks to repair them. And then in terms of planning, it is important to look at a number of things. One of them is definitely the landing zone. And the proximal landing zone must be in an area of normal aorta that is not affected by dissection. Most commonly, this is includes the distal edge of the subclavian, and occasionally we cover part of the left subclavian artery to achieve that seal. The presence of a retrograde intramural hematoma above the entry tear does not necessarily exclude that area from being used as a landing zone. So that's an important concept to consider when planning your landing zone. In about 14% of patients, the left subclavian artery is covered when you're dealing with the delayed repair in the high-risk group. In the complicated type B dissection, typically these patients don't allow you the time to do a revascularization procedure, and if you need to cover the subclavian, you just go ahead and do it, and then assess post-operatively. So in about 40% of patients, you will need to cover the subclavian. Contraindication to that, obviously, if there is a cabbage from a lima, or if the right vertebral artery is occluded, or the left vertebral artery terminates in the posterior inferior cerebellar artery. It's important to understand and image the vertebral arteries before you cover the left subclavian artery. And definitely, if a patient has a lima to the LAD, it's important to do a carotid subclavian bypass before you would cover the left subclavian artery. So after you have decided on your landing zone, you need to determine the size of the graft. So in dissection, we do not oversize. So there's zero oversizing proximally, and minimal oversizing is accepted distally, and we measure the entire true lumen and false lumen diameter. And then in terms of selecting the type of the stent, do not use a bare stent proximally. This has been shown to be associated with retrograde dissections. And also oversizing, going back to the prior point, oversizing does increase the risk of aortic dissection. So it's important not to oversize and use a 1-to-1 ratio for stent aorta at the landing zone, and to only use minimal oversizing distally, and avoid bare metal stents. I put this just for your reference. There are 3 FDA-approved stents currently on the market by Gore, Cook, and Medtronic, and there are a couple others that are available elsewhere by Terumo and Jotech. It's important to familiarize yourself with the stents and know their sheath size, their limitations, and before you engage in choosing which stent to use for your case. So the length that is needed to be covered is also important. So the length of covered aorta. There is also some controversy over this. What is for sure straightforward is that the entry tear must be covered. And then there seems to be better aortic remodeling if you cover all the way down to the diaphragm. So by covering the aorta from the left subclavian to the diaphragm, some investigators have demonstrated that you get better aortic remodeling. However, also the coverage of the aorta obviously puts the patient at a higher risk of spinal cord ischemia, and so you have to balance the two elements. So certainly use judgment in terms of how much to cover. I think definitely cover the entry point, and if you have a re-entry tear close by, it's reasonable to cover it, and consider bringing your stent all the way down to the diaphragm if your false lumen remains under pressure. So not blindly, but guided by IVUS. Look at your false lumen after you cover the entry point and then decide if you want to bring that all the way down to the diaphragm or not. How is this done intraoperatively? So femoral access, either percutaneously under ultrasound guidance with a suture-mediated vessel closure, or cut down, whichever technique you're more comfortable with. True lumen access and confirmation is very important. Using IVUS is the appropriate way to do this. If you don't have IVUS in your institution, putting a transesophageal probe in can do the trick as well to confirm intraluminal position in the true lumen. But familiarity with IVUS is extremely important to get this case done safely, and it is very dependent operator experience to be able to determine the position of branches, their patency, and the status of the false lumen. Localizing the entry point, this can often be done on the CT angiogram. If it's not clear, the IVUS is very helpful here, and also determining the position of distal fenestrations, which you may choose to cover if they are above the level of the diaphragm. Avoid ballooning of the stent graft. This can precipitate retrograde dissection. Now, using IVUS I think it is important during these cases in terms of confirming your position, the true lumen, localizing the distal and proximal tears, confirming the aortic diameter measurement. So this helps, again, corroborate the measurement from the CT scan and prevent you from oversizing. It is very useful in demonstrating dynamic changes in the true and false lumen after the initial stent graft that seals the entry point is placed. And also, it's very useful in assessing the branch vessel compromise, which may then lead you to perform an adjunctive procedure, such as a stent or a fenestration. Spinal drainage, should be strongly considered preoperatively, except in patients who are hemodynamically stable or have significant intraorgan perfusion. So if you're doing a delayed TVAR in a high-risk patient, certainly strongly consider a spinal drain. In the emergent situations, this usually is not possible. The drain should be about 15 ml per hour to keep the CSF pressure less than 10 in neurologically intact, and if the patient develops spinal cord ischemia, then in less than 5 millimeters of mercury. Not 5 millimeters, 5 millimeters of mercury. The TVAR complications include retrograde dissections, 2 to 20% of cases, paraplegia in about 5% of cases, and you can also get a TVAR-induced entry tear. This is the follow-up protocol for patients type B chronic dissections, other than, say, indications for these patients is 6 centimeters in diameter, or growth in the diameter of more than 10 millimeters per mercury, and that the role of TVAR is being established and requires further evidence to develop key criteria of where we can use it. Here, I would like to share with you briefly a very challenging case that we recently completed of a Marfan patient who came in with a type B dissection and a rupture, which was treated by a TVAR sealing the entry point and with only partial coverage of the left subclavian. Then 48 hours, he re-ruptured from a re-entry at the level of the celiac. Then we took him back to the OR and coiled the false lumen, and that has worked well and stopped the pressure in the false lumen. I'd like to conclude. I've included some of the references for you to go back to if you need to get an in-depth picture of some of the elements we've touched upon in this presentation. And thank you for listening.
Thank you very much, Yasir. I think we have overrun the session because of a lot of technical hitches as well as the talk. So let's move on to the next session of hot topics. My co-presenter or co-chair or my chair of this session would be Dr. Ilyas Sadiq. And can I ask Dr. Ilyas to just introduce the first presenter, Dr. Ziaur Rahman. Ilyas, please, can you join in? I think Dr. Ilyas cannot see him. I think he probably is joined at a different. Oh, here he is. Yes. Okay, Ilyas, Assalamu alaikum. Can you please introduce the next speaker?
Yeah, our next presenter is our friend Vardi, Dr. Ziaur Rahman. He is working as an associate professor and a head of the vascular department at Aga Khan Medical University, Karachi, and he is a fellow of the College of Physicians and Surgeons of Pakistan and hold a master's degree in the vascular and endovascular surgery from University of Edinburgh. He is one of the first few CPSP approved supervisors and examiners for the vascular surgery within Pakistan. Dr. Rahman is actively involved in improving vascular surgery training and research in Pakistan. And he has more than 60 publications in peer-reviewed index journals to his credit. He is very accomplished vascular surgeon. I would request you to put up his presentation, please.
I think Zia is presenting live, isn't it?
I think Ziaur Rahman is mute at the moment. He's not unmuted yet.
Dr. Zia, can you hear us? I think there is some sort of technical issue with his because we cannot hear him. Can we move on to the? If we cannot do that, then can we move on to the next talk because of the shortage of time?
So Khalid, should we move to Ahsan?
I think we should move to Dr. Ahsan, and then we can come back to Dr. Zia when he joins us.
Okay, No, Dr. Ahsan Manzoor Bhatti, he's graduated from Army Medical College, Rawalpindi, completed his general surgical training from CMH Rawalpindi in 2000 and passed his FCPS in general surgery in 2000. He's trained in vascular surgery from Heartlands Hospital and Charing Cross between 2004 and 2008, and he's passed his FRCS in 2008. He came back to Pakistan to rejoin Pakistan Army as a consultant vascular surgeon and presently working at a CMH Lahore. His educational interests include surgical training, especially training and assessment of surgical skills. So I would like you to request, please, put up the presentation of Dr. Ahsan Manzoor. I think Dr. Ziaur Rahman seems to be online.
Yeah, so, can you hear me, please?
Yeah, we can hear you there. Can you start your presentation?
Sorry for that. I share the screen. I am a bit not expert in this. Assalamu alaikum. So what is endo-AVF concept? This is important question when it comes. What are
sorry, the we cannot see your screen yet, I think.
Okay, sorry for that. So I am sharing it up. Start sharing. So I don't know how to actually show this it up. Cancel. And now I will go to the share part. Sorry for that. Share.
Yeah.
It should be on the bottom of your screen.
Yeah. Now I have opened the slides. This is the slide screen which I have opened. Are you able to see it up?
Not yet.
Not yet. So I am not sure how I can work on that. So can Dr. Ahsan take his presentation? I will work through it, sort out the issue in between.
Yeah, Dr. Ahsan, are you there?
Ahsan has a recorded presentation, so we can start Ahsan's presentation first. Seems that virtual.
There, can he listen to us?
Yes, they are going to bring up his presentation. He has a recorded presentation. So his
they're saying Ahsan's video is not available. Zia, did you sort out your issue?
I am working on that. I have actually uploaded my presentation on the this thing, and this is the.
Because they have a problem with the Ahsan's presentation. So if you.
So if you can see my presentation.
Yeah,
now
we can see it now. Yeah.
Sorry for
I think
interrupting.
you should go ahead.
Okay. So very important question when it comes from endo AVF. What is its core concept? What are the commercially available systems for performing endo AVF procedures? And how this procedure is done? What are its essential steps? And what are the clinical results of that? So endo AVF, there are actually in this, the vessels is not clamped, it is not mobilized, it is not dissected, and it is not anastomosed with sutures. So theoretically, there is less chances of vessel injury. So there is less chances of new intimal hyperplasia. And the AVF anastomosis is created in the deep vascular system, usually with the artery with a concomitant vein. And it is usually formed in the proximal forearm and close just proximal to a perforating vein. And this AVF anastomosis is usually performed by a percutaneous approach using radiofrequency or a thermal energy system. There are two basically systems available. I will discuss later. But what is the criteria for a patient for selecting a patient for endo AVF? The most important thing is the presence and adequacy of a perforating vein, because this ensures when the anastomosis is created between the deep venous system, the blood travels from deep system to the superficial system. And then the general selection criteria are the same as for selecting a patient for surgical AVF. That patient should not have a central stenosis, the vessel should not be calcified, the vessel should have a size of at least 2 mm, and there should be adequate superficial vessels to mature. This procedure is performed in conscious sedation and under local anesthesia. There are two systems available. One system is Everlink, which is using either a 4 French or a 6 French catheter. In this, there are two catheters and two punctures are made. And these catheters have potent magnets in order to adopt to the target vessels, artery and vein, for the creation of anastomosis. The arterial device has a small ceramic saddle between the magnets, and the venous device has an arcuate electrode that ideally should perfectly sit in the ceramic. So this is the two catheters which has been placed. This is the arterial catheter. This is the venous catheter which has been placed. These are the magnets which has coapted, and this is the point where the anastomosis is going to be created by radio frequency ablation. And when the anastomosis is created, the blood flows from here through the perforating vein into the superficial vessels, and vessels get matured. To prevent the blood going to the different system, deep system, coils are placed into the deep brachial veins. And so the most important thing is the preoperative ultrasound, in which we see the size of the vessels, we see the size of the perforators, and it should be 2 mm. And depending upon the vessel's adequacy, either access can be taken from the radial artery or it can be taken from the brachial artery, and both artery and veins are actually punctured. And usually ulnar side at the proximal forearm is chosen, and the procedure starts in light sedation when the local anesthesia. The arm is placed and fixed on a carbon arm board and transparent to imaging to prevent movement. Normally, there is nerve stimulation and a strong muscular activity, and actually there is jerk movement that has to be prevented. When there is sonographic puncture, then 0.14 guide wires are placed into both vessels, and then both catheters are placed. Then magnets actually coapt, and then there is the preset high frequency energy of 60 volt is applied by manual control, and a pre-programmed timer of 0.7 to create an endo AVF is done. The created anastomosis always has the same dimension with the size and the length of the saddle on the arterial catheter. The result is documented by a fluoroscopy, And in most of the cases, coil embolization of deep brachial vein is performed proximal to anastomosis and perforating vein, as I have told you. So this is the anastomosis which has been done, and this is the coil embolization which has been performed. This is the system which we use. This is the pad. These are the catheters. These are the magnets which has been used, and they coapt. What is the clinical efficacy of this procedure? First, there was 2 or 3 landmark studies which has shown efficacy of making endo AVF by using these catheter system. One was the Flex system. It was a prospective clinical trial. It shows technical success was achieved in 32 out of the 33 patients, that is 97%. And in 96% of the patient, fistula was matured after 3 months and can be used for dialysis. Then there was a multi-center, multinational study, which was novel endovascular access trial. It has a follow-up. It enrolled 80 patients, and it used 6 French system, and it shows high technical success, that is 98%, and there was functional patency was 87% achieved. And then we have studies, prospective studies using 4 French system, which shows good technical success. Then there is another system which is available in commercially, which is known as ellipsoid system, in which actually we use the same technique, we use the same criteria, we use ultrasound, but instead of 2 punctures, we use 1 puncture. We puncture superficial vein, either the basalic or the cephalic vein, and going through the perforator veins, and then crossing the vein into the artery, and then 0.014 guide wire is placed, and over this ellipsoid catheter is placed. It has 2 pairs. One is placed in the vein, one is placed in the artery, and then the thermal energy is given. Instead of radio frequency, we give thermal energy, and it produces an anastomosis. But it immediately required a balloon angioplasty to make it patent. Otherwise, it gets stenosis. So, and in some patients, it requires coil embolization. So there are 2 trials which have shown efficacy of that. First was the TRAD trial. It shows technical success of 88%. That is 23 out of 26 patients, and that was published in 2017. And out of them, 22 were patent after 6 weeks with an average time of starting dialysis of 108 days. And in most of the patients, that is 48 patients, required additional PTA. Then another study, that is pivotal trial, that was done on 5 centers in the USA, has shown the efficacy, technical efficacy of 95%, and 2-night needle dialysis was achieved in 88% of the patient. In these patients, many patients do require additional procedure. One was actually angioplasty, which is prerequisite, and some patients require coil embolization. If I compare both systems, one actually required 2 access site, one required 1 access site, and in wavelength system, we only use the coiling of the brachial vein, whereas in ellipsis system, it required regular PTA of the anastomosis. But both systems are quite effective in technical success and in maturing the fistula, which are usually functional. So the critique come of their cost, and Yang et al. Actually did a study in which he used the same patients as was done used in NEAT study with a historical cohort from American insurance data that shows pretty much the same patient demographic. More than 1 year after surgical and endovascular creation of AV fistula, the complication, reintervention, and central vein catheter exposure time were compared. Significantly low rate of angioplasty, thrombectomy, surgical revision, central vein catheter grafts, new fistula creation, and access-related infection in the endo-AVF group led to saving benefit of more than $11,000 US compared to conventional surgical creation of AV access. So it is making its place in the patients requiring hemodialysis access. So if I conclude, the most important 3 or 4 points which has to be remembered. for standard placement of endo-AVF, the perforator vein is indispensable. 2 procedures are currently commercially available. Ultrasound and high-quality radiological imaging are very necessary. The technical success rate in these studies are more than 90%, and it is now created with higher success rate and very low complication rate. And with appropriate patient selection, both commercially available catheter system demonstrated higher functional primary and cumulative patency rate even after 12 months. Thank you for your listening.
Dr. Suhail Choksi. He's a consultant and vascular surgeon at East Suffolk and North Sussex Foundation Trust. He's trained in Bart's Hospital in London, East Anglia, and South Yorkshire. He's been a consultant for the last 15 years. Can we please share Dr. Choksi's slides?
While I wait for the slides, Assalamu alaikum. Thank you very much for the invitation to talk today. It's a privilege. I'm a vascular surgeon, as Khalid said, in UK, and I'm a carotid surgeon. I don't do any carotid stenting as such, but as with most UK centres, carotid endarterectomy is the dominant technique. And I will be presenting the slides in a minute when they come up. It is nice to see so many colleagues today in this very excellent session on vascular surgery.
Thanks, Suhail. We would love to listen from you.
Absolutely. I'm just waiting for the slides to come up, and I'm trying to make small talk as well while I'm waiting. I'm sorry. I've uploaded the presentation, so it should be available. I'm sure that, there we go. Thank you very much. Right, okay, so I don't have any declamations to make. My talk will concentrate on 4 questions, because I've been asked to talk about carotid endarterectomy versus carotid stenting, the evidence for that. And the 4 questions that I'd like to be able to answer is, firstly, what's the evidence for carotid stenting in symptomatic, asymptomatic disease, and in early carotid endarterectomy as well. I seem to have lost my slides at the moment. There we go, they're back again. Excellent. All right, so background, carotid stenosis causes about 1/5 of all ischemic strokes, and we know that the prevalence is around 7.5% of men under 80 and 5% of women, so it's quite common, and we often see in asymptomatic patients as well. Carotid endarterectomy is an established operation. In fact, DeBakey did the first one in 1953, but Eastcote published it in 1954. We know the trials, the North American trial and the European trial, both which showed that there was a significant benefit in doing carotid endarterectomy in patients with symptomatic carotid stenosis. Carotid stenting, there are potential advantages. You avoid an incision, an operation, less chance to damage the nerve, good for accessing lesions that you cannot access surgically, and also perhaps in lower risk and higher risk patients. The first stenting of a vessel in the circulation, brain circulation, was by Vitek in 1984. and stenting has been found superior to carotid angioplasty. So that's now the technique that is used dominantly. There are protection devices used to reduce the risk of embolization, which can be proximal occlusion and distal embolization protection. Looking at the non-randomized data for carotid stenting, we know that in the European registry, there were 1,600 patients. About a third of them, or approximately half of them, a third of them were actually symptomatic, and the stroke rate was around 1.36%. The German registry, over nearly 6,000 patients, about 50% of them were symptomatic, with a stroke rate of 2.8%, and then the US registry with around 5,800 patients with a stroke a death rate of 6.12%. So a variety of results. So my data that I'm going to present, it's quite easy really, because a recent Cochrane review has been performed in 2020, which has built on previous reviews, Cochrane reviews. The latest iteration is the 2021, and it looks in a lot of detail comparing carotid stenting and endarterectomy. One of the things that I wanted to ask specifically is, what is the long-term evidence of carotid stenting? And there was very little evidence before this review on asymptomatic carotid disease and stenting. Now, I'm just going to run through a few forest plots. I'm sorry it's a bit small. Hopefully you can see my cursor, but this is the sort of main slide, I suppose. It's stenting versus endarterectomy for symptomatic carotid disease, death or any stroke between randomization and 30 days, perioperative stroke. So there is clearly an advantage for a carotid endarterectomy versus carotid stenting. So this is a forest plot. So this favors the plot on the right of the line favors endarterectomy, and on the left of the line favors stenting. So you can see that the odds ratio is 1.7 approximately, and is highly significant. Age seems to be a factor in patients who are young. In fact, carotid stenting and carotid endarterectomy seem to have similar safety profiles. But in the older patients above 70, which is really, I suppose, the majority of the patients we treat, it appears that there is a clear advantage for carotid endarterectomy, and the odds ratio is 2.23. And overall, there is an advantage, as we know. Sex doesn't seem to make a difference, male or female sex, which is an interesting observation. If you look at the fatal stroke or death, if you compare the two, it appears that there isn't really that much difference between endarterectomy and stenting. The odds ratio is 1.3, and it's non-significant. Now, if you look at the long term, now this is beyond 30 days, up to the follow-up, end of the follow-up. This is quite a useful slide to show that there is a benefit of long-term benefit of endarterectomy versus stenting. Now, interestingly, if you take out the perioperative sort of stroke rate, then they're actually quite similar, which indicates that the technique of stenting and endarterectomy have a similar sort of effectiveness after you've excluded the perioperative risk of stenting. What about asymptomatic patients? Now, I'm not sure really how relevant this is in UK practice, because the vast majority of patients who are asymptomatic tend to be having best medical management nowadays. However, if you look at the results, there is a trend towards a benefit for endarterectomy, but this isn't significant as such. And in terms of disabling stroke, it's even less so. When you look specifically at patients who've got increased surgical risk and look at the outcome of death or stroke, there isn't really much difference between the two. So, in other words, there's no advantage of doing a stenting. However, I suppose the more relevant thing is there a decreased risk of MI? And there is a non-significant decrease in risk of MI in patients who have stenting, but this is non-significant. What about restenosis? Again, there is a benefit. Carotid endarterectomy has a lower rate of moderate or severe restenosis. For severe stenosis, it's similar, but for moderate and severe, it is greater with stenting. In other words, it favors carotid endarterectomy. Cranial nerve injury, well, there's certainly strong evidence from these analyses that there is a benefit for carotid stenting here. The odds ratio is very sort of, it's 0.1, which is extremely significant as well. And also in terms of access site complications, in other words, bleeding, hematoma is less for carotid stenting. So just to recap some of the information, symptomatic disease, there's two bits to it really. I suppose there's the safety element and there's the efficacy. In terms of safety, carotid endarterectomy is a safer operation, particularly in over 70s. And in asymptomatic patients, there's no real significant difference between the two. For carotid stenting, there is a lower risk of MI, cranial nerve injury, and access site hematoma. And in the long term, carotid endarterectomy is better than carotid stenting, but if you exclude the peri-procedure events, there's no difference. Overall restenosis rates for moderate or severe stenosis is more common in carotid stenting. In terms of efficacy, though, they're both equally effective. I think the only thing that is useful now, having established this, is when do we do carotid intervention the most? It's done early in symptom onset, and it's encouraged to do that early because we know there's a benefit. And we don't really do it very much for asymptomatic disease in the UK. So this is a paper that was looking at specifically at early endarterectomy and early carotid stenting. And they looked back at the 4 trials, the EVA 3S, SPACE, CREST, and ICSS, and they did a pooled analysis. This is a paper from 2017. And what it showed is that now you'll notice that there were 226 patients, or around 200 something patients in each group, and the actual number, this is a minority of the number of patients in the whole trial. So in other words, the vast majority of patients in these trials were done after 7 days. So, which I'm not sure reflects modern vascular practice, where we try to do it as soon as possible. But nonetheless, it gives, it does give a good number of patients that we can compare. And if you look at the odds ratio in these patients, it's around 6.5. In other words, and that's very significant. So that's in favor of carotid endarterectomy. If it's if it's within the first 7 days. If it's greater than 7 days, then that drops to 2. And that could be, this is for stroke or death. And it's very similar results for any stroke or fatal and disabling strokes. And I suspect that's due to the instability of the carotid plaque initially. And again, is perhaps something that must be considered if carotid stenting is being advised or recommended in a patient. So most importantly, what is the implications for practice? Well, we can say that both procedures are equally effective, but carotid endarterectomy is safer for patients, particularly early after symptom onset. Carotid stenting should not be used routinely in patients over 70. Carotid stenting may be indicated in surgically inaccessible lesions, previous surgery, previous nerve injury on the other side. For example, if the vagus nerve has been damaged and there's the other side, obviously it could create a problem. In some higher risk patients and possibly in some younger patients as well. Carotid stenting should be avoided after early symptom onset, and it should. This is something that we've gained from reading the papers, is that it should be performed in places where high volumes of stenting are performed. So that's the evidence. I hope that you've found this useful, and I'm happy to answer any questions. Thank you for listening.
I think, thank you very much for your presentation. Can we move on to the next presentation, please? Can we ask Professor Iqbal to join me for the next session? Ilyas, we are not going to do Ahsan's talk for the moment. We are very short of time, so we're going to move to the next talk. So it will be next. Yeah,
that's fine. Thank you.
Okay, can we please get Professor Iqbal as well, please? Can we ask him to join us? And the speakers in the back. Dr. Iqbal, can you join us, please?
Can you hear me?
Okay, Professor Iqbal, can you please introduce Professor Atikur Rahman, please?
Sulaiman, it is my pleasure to introduce Professor Atikur Rahman, who is a graduate of Rawalpindi Medical University, and then he moved to UK and had his surgical training, basic surgical training in vascular from St. Mary's University, London. Was awarded the honorary professorship from the University of Birmingham in 2019 for a contribution towards the medical education. He is currently a sub-dean for University of Birmingham Medical School, and also he is director of medical education at Russell Hall Hospital, and the clinical director for surgery, urology, and vascular surgery.
Okay,
Hi, Khalid.
Please start.
Khalid, sorry, I think I'm having some difficulty sharing my slides, and there was some issues as well from other end. I sent it across, so I did try, but I for some reason I can't share. But can I just quickly talk about this? Is that all right? Hello, can you hear me?
Let me see if I can do that from my end. I might have your slides.
I did send the slides just literally very lately to Maria as well again.
Okay, let me see what I can do here. I mean, you can start talking. I will see if I can share your slides.
Okay, what I'll do is as I said, I've sent the slides to Maria, but if you want me to, I can, just because my earlier presentation was with sound, so that might have some challenges, but you can try and while I talk. So what I was going to say is, obviously, we work in Black Country Vascular Network, and the Black Country Vascular Network is consists of 3 hospitals, which is one is New Cross Hospital in Wolverhampton, and Walsall Manor Hospital, and obviously Russell Hall Hospital in Dudley. We are very close to Birmingham, and in this our network there are 8 vascular surgeons, and we have 6 vascular intervention radiologists, and we have obviously a very dedicated vascular ward. Very soon we are due to have a hybrid theater as well. At the moment we don't have, and we have all the other access to vascular images. We don't do any obviously here in Russell Hall, which is the arterial center, after obviously all this vascular reconfiguration what happened nearly 10 years ago, and we performed the major arterial work in Dudley. We don't do any carotid stenting, but we do obviously carotid surgery. We do very complex arterial peripheral arterial work in terms of vascular reconstructions, and this includes complex hybrid distal procedure. We have a fair number of diabetic patients. As you know, the prevalence of diabetes is getting incidence is increasing in this country even, and we see lots of diabetic patients, and I think that's most probably is one of the major work, and we are one of the major center performing a lot of distal reconstructive surgery. We do aortic obviously surgery. We don't do any aortic stent, thoracic stent. We certainly do infrarenal aortic stent, and 70 to 80% of our aortic work is endovascular. About 20% is complex, I would say, juxtarenal, aneurysm work. And we do have a very dedicated intervention radiologist here who obviously do the complex infra genicular, all those complex pedal angioplasties, that sort of work. We have obviously the venous surgical interventions happening across our 3 sites, the other sites in the network, and we also have a lot of renal access work. I was listening to an earlier presentation about very advanced AV endovenous fistula formation. I'm afraid we don't do that. We need to most probably learn very soon. So what I was going to say about the training is we had a memorandum of understanding with College of Physician and Surgeon nearly 4 years ago, where we thought we will get the juniors and senior trainees from Pakistan, and we will ask them to come in our hospital, and that's not just in vascular, across the whole organization. And in fact, after the initial understanding and joining with the college, had various meeting took place, and we started the program. I think the first time we did the interview was back in September 2018, and we selected the trainees at the different grades, and there was a junior and senior fellows. Primarily, most of the trainees in our hospital came in medicine and acute medicine and general medicine, but there was trainees also in general surgery, orthopedic surgery, and gynae obs. And certainly I found an opportunity, maybe we should have trainees in vascular as well. So that's the time we started the program, and they were coming at the 2 levels. One was at the junior level, called as a junior clinical fellows, and the one trainees after their FCPS, obviously fellowship program in Pakistan, they were coming as a senior level. Most of the trainees in general surgery and in surgical specialties was seniors, but in medical specialties, primarily the trainee did come at a junior level, which was after their while they were postgraduate trainees in Pakistan, what they call PG 3 or 4, following their IMM exam. So we obviously got them here, so that the rest of their program they can complete in our hospital, and then they can go back to Pakistan to complete their fellowship and all of that. So there was a very robust selection process. All the jobs are advertised in the college website, and then we interviewed before COVID, traveling to Pakistan in a different center. But now, in last couple of years, we're doing all the Zoom interviews. And after those interviews, after selection, then we had, obviously, these are the trainees post. We had the permission from Health Education England, and then we had permission from Academy of Medical Royal Colleges. Our hospital is the sponsor of the GMC, so we got the GMC registration for all those trainees. We sorted this out, and after all these logistics, which takes roughly about, I would say, 3 to sometime 3 months, sometime even 6 months. It depends upon the candidate how quickly they respond. So we once they get the visa, they come here. We do the very robust induction for 1 month, and during that month they get the free accommodation, and then obviously they go through all the mandatory training and all the Welcome UK package, and after that they formally start the program. They are paid their relocation charges and they are paid the scholarship. So far, I would say we all across the organization, we had almost well over 100 trainees, who came from Pakistan, and they really enjoyed, although there was some always challenges, some hiccups, but most of them passed their, either in medicine, their membership program, or in surgery, their MRCS, and some of the trainees even gone for exit exam and did the FRCS as well. And during that time, we obviously try to equip them with all the clinical knowledge and skill, which obviously we know they're all very bright trainees. And we also try to give them some other, leadership skills and all of that. I think the key, what I would say was, in vascular, while this program was all developing, I had an opportunity to, as I said before, to get some vascular fellows here. So the vascular fellow was all coming as a senior level. They were all post fellowship, and so far we had 4 vascular fellows. 2 of them finished and they have moved on, and the 2 of them are almost finishing the program, and we are due to obviously do some more interviews very soon within the next few weeks. Hopefully, certainly 1, maybe possibly 2, to take 2 more vascular fellows, in our hospitals. They all, obviously, the reason to expand earlier was what opportunities they have. They all have an opportunities to go to a major vascular list. They like to be involved in obviously the distal reconstructive work with the lower limb bypasses and all of that. They have an opportunity to attend our endovascular sessions. They have an opportunity to go to all the venous work, endovenous work, and they are formally part of our, the rota. And we try to obviously give them the maximum opportunities, but one could imagine there's always a bit of competition, which happens. But we try to protect, their learning opportunities. So I would say it's a very very good program for those trainees. And during that time, I must say, we also had, with the help of, in fact, Professor Ahsan Bhatti, Brigadier Ahsan Bhatti. So he obviously sent a couple of trainees on OJT team from the army. 2 trainees have been with us. They have gone back, and I think 1 more is due to come, and that is contact to Ahsan Bhatti. One of the other things which we are due to start is the formal leadership program for all these trainees who come from Pakistan on this MTI scheme. And that really I found is very, very useful for them. Most probably will be very useful for them, because we do acknowledge that when the trainee comes here, they have a lot of obviously knowledge. There's no doubt about it. They pass their MRCP, they have passed their MRCS very quickly. One thing they do lack is the communications and all the other soft skill, which our local trainees certainly have a little bit more advantage. So once I've identified some funding, I'm going to enroll most of our trainees to our NHS leadership program, and we are looking at least 10 fellowships with NHS leadership, and that will give the formal, I would say, qualification like MSc in medical leadership and management, and that will be again a very quality improvement program with the College of Physician and Surgeon. We want to expand this program with other universities in Pakistan, so that's not really only to a certain trainees. It is widely expanded, and on this program, I must say there are other hospitals in this country, like in Birmingham, I know UHB, Heartland, Walsall Manor, and then up in North, Newcastle, Leeds, and some other big teaching hospitals are involved as well. There are at least 6 or 7 altogether hospitals in England who are heavily involved in this program. And if we also have obviously talked in our own vascular forum here in England, if we can take some trainees and expand these opportunities to a lot of trainees who wants to come on a 2-year dedicated program, I think that will be really good. But I'm very excited about this leadership program as well. Sorry, Khalid, I couldn't share my slides, but I'll be very happy to answer any question. Thank you.
Do his talk, and neither we could do Zahid. We will be able to do Zahid's talk because there is another session after this. I will ask Professor Iqbal if he wants to ask any question from Professor Atik regarding the training in vascular surgery in the UK. I think his is working.
I know there seems to be some problem with connection.
Yeah.
Khalid.
Ji Iqbal Sahab, do you want to ask any question from Atik regarding the training, because you are involved in the training of vascular surgeons in Pakistan? I must congratulate you, Atik, for doing all this effort for all the trainees in Pakistan, and it's really very useful for the trainees, I must say, and hopefully this will continue, and more trainees would like to come and join and get trained and come back to Pakistan and spread the vascular surgery in the country, which I think is required. And I think Zia and Ahsan and Omar and Iqbal Saab and Sufi Saab, all these people have actually done a tremendous job in keeping the torch in keeping the torch up for the vascular surgeons in Pakistan, and I congratulate everybody. And thank you very much, everybody. I'm very sorry for all these technical problems, and unfortunately, this was the first time for me, as well as first full virtual meeting for Indus as well. And unfortunately, none of us are there in Pakistan. Everybody is outside Pakistan, so we couldn't have a direct contact with everything, although everything was passed on, but still there were some glitches. So again, very sorry for that. I hope you have enjoyed the session. Inshallah, next time we will have a longer and a better session with less technical problems. Thank you all. Thank you very much.